seems to be the kind of going thing around this area. Sometimes you'll have that, that one person that's pushing 2 grams, which is fine. But, it always comes up when, we're actively resuscitating a patient, but I don't know really if it is or not. And, most of the literature that, studies TXA doesn't really report hypotension as a significant side effect. So I'm not sure. It probably has been studied a few times before, but I'm not sure if I see it clinically.
Yeah. And I always wondered, because I can't figure it out, how this would happen, because it's not acting on the vasculature, it's acting on the clot itself.
Do we understand everything that we do all the time? And I don't know if I can honestly say that, because there might be things that we don't know that we're doing that are happening that either benefit us or don't benefit us. We don't know. And that happens routinely throughout the history of medicine and surgery.
Oh, yeah. I'm sure, did the patient live because of you or despite you?
Yeah. Yeah, that's a good way to put it.
Earlier we were mentioning like the gram up front, the drip over time, which kind of leads into one of the new TXA updates that hasn't really been like solidified yet, but it's definitely been a thought for quite a while, is IM dosing of TX. Now, if you're talking about a healthy person, that makes perfect sense. Like, it will get into the vasculature. You will get your plasma levels. It'll do as advertised. But in a trauma patient, they're shunting. They're losing their blood in the skin. They're losing their blood in the muscles, all going to the core. I guess I don't really understand, why is TXA okay in this situation when all the other medications that we talk about, narcotics or antibiotics or whatever, in that type of patient, it's not recommended.
Yeah, and that's a great question. Originally the discussion in a study that I was a part of is whether, we could just even give TXA through an IO. I mean, that was the first discussion on this. That was shown to be about equally as effective as giving it IV. So we know I think with all IM medications, and when there's an IV or intraosseous, it's going to be less effective. Now, IM TXA really hasn't been studied on a super large scale, but we know it's safe. And we know that, to really truly shunt, from the periphery of your skin, you got to be, probably in your higher classes of shock, 3 or 4. And that also depends on if you're dehydrated, cardiac output at the moment. And that's why it's so important to give that TXA early. If a patient arrests, the blood's not going anywhere. So even the TXA, it's given IV, it's not going to do anything. So they try to give it early.